everyone, and welcome back to another insightful episode of MedSynapse podcast series. I'm Hetvisha, your host, and today we are thrilled to have with us Dr. Premjit Jungtongjin. Dr. Premjit is a leading dermatologist based in Thailand, known for her innovative and patient-centered approach to treating complex skin conditions. She's currently an associate professor in dermatology at Thammasat University in Thailand. Doctor has made significant contributions to the field of dermatology with a special focus on autoimmune skin diseases, including psoriasis. She has been actively involved in both clinical practice and research, exploring the latest therapeutic options and advancements. And in today's episode, we'll be discussing treatment options for managing psoriasis, a topic that is critical for both patients and healthcare providers. And Dr. Premjit will guide us through the latest breakthroughs, challenges, and future direction in psoriasis care. So, welcome to the podcast, Doctor, and we are so excited to delve into the discussion today.
Okay. Sawadika. Okay, thank you very much for your very kind introduction, Happy. Yeah, so it's my honor and it's my pleasure to be here today.
Thank you, Doctor. So, to kick things off, could you explain the underlying pathophysiology of psoriasis and how our understanding of this condition has evolved over the years?
Okay, so first of all, you have to know first that psoriasis is a complex and chronic inflammatory skin disorder that we don't know the pathophysiology exactly, and we believe that it's caused by multifactorial. However, with the problem maybe from the genetics, environmental factor, or even immunological factors that can activate the patients to develop psoriasis. Once the patient gets the trigger by something, maybe from the infection or from trauma or from stress, it's like open the switch for starting getting psoriasis. In pathophysiology of psoriasis, we have known more and more. Right now, we have seen that in psoriasis skin, okay, there's a lot of leukocyte recruitment to the epidermis and dermis, and later to get developed as a psoriasis and cause epidermal hyperplasia, hyperproliferation. This involves many cells, especially T cells involvement. Lots of T cells are aggregated into the dermis and epidermis. Majority after keratinocyte has been activated is stimulated to myeloid dendritic cells, and later develop induce many cytokines and T helper, including T helper 17. This is the major of the cells that right now we believe this is a major T cells to release of the cytokine IL-17, something like that, including IL-23 to go back to stimulate keratinocyte to get more and more epidermal turnover and hyperproliferation. This is basically what is the pathophysiology that we have known right now, but sometimes we still have some missing puzzle that not understand exactly. But right now, the majority is about T cells. Many cytokines involvement, including TNF alpha, IL-17, IL-23, something like that.
That is really fascinating. And now, could you discuss some of the current challenges in diagnosis psoriasis and any recent innovations in diagnostic techniques that healthcare professionals should be aware of?
Actually, we can see psoriasis up to 3% of the population. And majority, as for the classic presentation, we can see the thick red plaque of the skin with thick scalp or silvery scalp on the scalp, on the skin, especially at traumatic area as like elbow, buttocks, and trunk, knees, something like that. And patients will have nail involvement. And in more severe, the patients may develop psoriatic arthritis as well. This is the classic type of psoriasis. Majority is the plaque type. However, there are many types of psoriasis, many manifestations, including like the type we call gutted psoriasis. It's going to be like a small patch that we call papillosquamous disorder. Once the patient has this clinical features, we have to differentiate differential diagnosis with other papillosquamous disorder like pityriasis rosea, pityriasis lichenoides chronica, or even secondary SY, secondary syphilis, have to be differential diagnosis. Another type of psoriasis may include like pustular psoriasis. Patients may develop pustule, many pustules that we have to differentiate diagnosis with Egypt, one type of the drug eruption. And the most severe cases of the psoriasis in general like erythema or that we call erythroderma. As we know, erythroderma can be many skin diseases, including infection, like 4S infection, inflammatory skin disorder like psoriasis, atopic dermatitis, or even skin cancer like Sézary syndrome can be one of the differential diagnoses of erythroderma. So I would like to say in terms of diagnosis, if in classic type, it's not difficult. But if in not the classic type like plaque type, it maybe need like a clinical experience to help for diagnosis, or even if you doubt or not clear for the diagnosis, you may have like a skin biopsy to check for diagnosis and see for the overall, may not just only skin, because right now we know that psoriasis is beyond skin diseases. It may involve nail, involve scalp, involve joint pain. And most of the patients may have like a metabolic syndrome, which we can see a little bit obesity, hypertension, diabetes, hyperlipidemia, whatever.
Oh my God, that is vast, I think. So, just one question out of curiosity would be, how can you early detect this disease? Like early detection, how can it be?
First of all, it cannot be prevented, I would like to say.
No.
Yeah, it cannot be prevented. It depends on the skin disease clinical features. 80% of the patients will firstly develop the scale on the scalp, maybe the first location. However, in the beginning, it's quite difficult to distinguish between scalp psoriasis and seborrheic capitis, which is very common, like a seborrheic dermatitis. But the thickness of the scalp and thickness of the plaque will be less than scalp psoriasis. So that's why we need to keep an eye on the patients. If the patients have chronic skin problem, so we have to keep in mind, ask for more information, ask for family history about psoriasis or many things.
Thank you for sharing that, doctor. And now moving on to the treatment part. Psoriasis management often involves a range of options. So could you elaborate on the differences between conventional therapies and biological therapies for psoriasis? And how do you decide which treatment is appropriate for a particular patient?
Okay.
This becomes very difficult sometimes for the healthcare professionals.
Yeah, the treatment of psoriasis is quite very developed during the past 10 years, I would like to say something like that. Normally, we choose the treatment option regarding to the severity of the patients. Okay, the treatment options include four things. The first one is topical treatment. The next is oral systemic treatment. The third is like a phototherapy treatment. And the last one is like the advanced treatment like biologics. Okay. For the majority of the patients, it's just only mild severity. In mild severity, we can just have topical treatment. The topical treatment that often include topical steroid, topical vitamin D analogs, and tar preparation. This is a major three things apart from emollient and skincare that all of the skin patients have to be take care of it. Okay. For others, moderate to severe patients, the doctor have to offer more aggressive treatment, I would like to say. The aggressive, as I mentioned, systemic treatment, phototherapy, and biologics. Conventional systemic treatment often include methotrexate, acetylcholine, which is a systemic retinoid, and the third thing is cyclosporine. Each of them have their own limitation, as you know. Methotrexate is one of the immunosuppressant, and the patients have to be monitored about hematologic abnormalities and liver function, liver toxicity. And once you take the methotrexate, you should not get pregnancy. This is the drug in pregnancy category X. Okay, the next one, acitretin, which is a systemic retinoid. Again, it have good efficacy. However, it also have adverse reaction that we have to monitor, including liver toxicity, hypertriglyceridemia. And again, the patients cannot get pregnancy during taking this medicine because this is the retinoids. The patients have to discontinue retinoids at least 3 years before getting pregnancy. Okay, and the third one, as I mentioned, cyclosporine. Cyclosporine, as you know, is one of the immunosuppressive medicine, as can cause toxicity to kidney, and it can increase blood pressure. So that's why in each medication you have to know the efficacy and the adverse reactions, and then we can adjust in individual patients. The next one, phototherapy. This is very good for the adverse reaction because this is very safe for the adverse reaction because it's like you go into the booth and get the UV exposure. It's not involved internal organ, so it's very, very safe for kidney, safe for liver. However, the limitation is that you have to go to the hospital or you have to go to the center at least 2 or 3 times a week in 20 to 30 consecutive sessions. So it takes time, and you need to go to the available center. That's all. And finally, the last is like the advanced technology right now that we know a lot, biologics treatment. Previously, we have anti-TNF group, but recently we have another group that includes anti-interleukin. As I mentioned, in the pathophysiology, right, it's involved TNF, but we know that if we block anti-TNF a lot, we may increase the risk of develop infection. Right now, we have more specific target for skin condition to target to treatments, to target to anti-IL-17 and IL-23. So this is another group for very, very effective treatment for psoriasis right now. So come back to who is the patients that we should get the conventional or biologics, right? It depends on, firstly, you have to check indication of the patients. If the patients have joint involvement, topical is not enough, right? Okay. If the patient have severe psoriasis, or if the patients suffer a lot from psoriasis and affect the quality of life a lot. If the patient has the area involvement in difficult area to treat, such as on scalp, at nail, at intertriginous area, on face, palm, and soles. These are the areas that are difficult to be treated. So, if the patients did not respond to the topical medication, these are the indications for the patients to have more aggressive treatment, such as like systemic and biologics treatment. Okay, so we have to monitor and consider many aspects of the patients before we prescribe any medicine. And also we have to discuss pro and con with the patients. We have to make a decision together.
Yes, that's quite an comprehensive approach, I would say. Now, speaking of emerging treatments, what are some of the most promising new therapies for psoriasis that are currently being researched, and how might they change the landscape of psoriasis management in the near future?
Okay, as I mentioned earlier, that psoriasis is involved in biologics, right? And the emerging right now, very promising right now, the biologics in terms of oral. Because right now we have biologics in terms of injection. The patients have to be pain and get inject every month or every 2 months or every 3 months or whatever, depending on the protocol of the injection. So right now in this year, in 2024, this study has just recently been published in New England Journal of Medicine, the major journal that we have known. The oral anti-IL-23 receptors antagonist peptide to treat psoriasis. Interestingly, because its efficacy is maybe a little bit lower than the standard injection of biologics, but however, it's not pain, and it will be more patient acceptable. Yeah, so I'm looking forward to see this one.
That future looks really promising, I think.
Yeah.
Now, as technology continues to evolve, as we've seen in the past also, so how are the advances such as teledermatology and digital health tools influencing the management and treatment of psoriasis?
Yeah, I think with the technology, telemedicine will be very, very helpful in the patients with chronic skin disease. Okay, it's not only chronic inflammatory skin disorder, maybe another non-communicable disease as well, right? Okay, chronic disease. Because this one can help the patient to save time, right? And save money, save costs, save time to travel for transportation, and very convenient. And it's another way for the patient to see the specialist directly, because sometimes the patients have to see family doctor, general medicine. They cannot access to see the dermatologist right away. So this is a good way. Okay, and regarding to the journal recently published in ACTA-DV about the question is that, is telemedicine suitable for patients with chronic inflammatory skin disorder? In the systematic review, interestingly, it says that telemedicine is equivalent or not significant difference from traditional in-person care in terms of safety, disease activity, and quality of life. And again, the advantage, as I just mentioned, save costs, reduce the travel distance, reduce the transportation, and save time for the patients and also doctor as well, right? However, there are some limitations that we have to keep in mind to concern. Like for me, I prefer to get at least the first time to see the patients before enter to the telemedicine. Because first in the diagnosis and thoroughly physical examination, I still think in person will be get better in terms of get the complete examination and get the patient doctor relationships. Okay. However, as for the telemedicine, maybe have the limitation in this point for patients doctor relationships, and also in terms of what I have to say, human touch or empathy, because this is the chronic skin problem. Patients suffer from this disease for a long time, not only themselves but also their family. Yeah, being a doctor in this field, I can help them, even just touch on their skin, because I know that it's not contagious. Okay, to say, or give a hug. Okay, it means a lot to the patients, and telemedicine cannot do that, I would like to say.
Yes.
Yeah, and another thing is like the assessment for the severity. Sometimes I need to roughly see physical examination to assess the severity with the PASI score. However, I think it's quite challenging in the near future. AI or take a very good resolution of photo may help me, or may help the patients in order to evaluate the severities of the patients. And this is very important for doctors to make the decision and continue treatment in the long term.
Yes, rightly said. I think there are some limitations, like something like human touch cannot be replaced by telemedicine. So, but it is intriguing to know that.
Yeah.
Now, one question before we conclude is there any final piece of advice you would offer to healthcare professionals dealing with psoriasis patients?
Okay. Right now, the treatment of psoriasis is quite advanced. Okay. As a dermatologist, I have to keep update for more information, for more practice in this area. In terms of healthcare provider, as a healthcare provider, if you see the psoriasis patient, please feel free to refer the patients to see the real expert as a dermatologist, because the medicine is quite advanced right now. And the treatment can show impressive result. The skin can be clear, completely clear, and patients can go back to continue their life, okay, as a general people. So please encourage patients to get the adequate treatment.
Thank you for that lovely piece of advice, Doctor. Now, as we wrap up this insightful discussion on managing psoriasis with Dr. Premjit, we have gained a deeper understanding of both the evolving landscape of the treatment options and the latest advancements in dermatology. And Doctor, I would like to tell you that your expertise and passion for dermatological care have truly illuminated the complexities and innovations in managing these chronic conditions. And thank you so much for sharing your valuable knowledge and experience with us today.
Okay, it's my pleasure to be here as well.
Thank you so much, Doctor. And to our listeners, we hope you have found this episode as enlightening as we did. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not forget to join us on MedSynapse platform. MedSynapse platform is not just a resource. It's a dynamic space where you can connect with your medical peers, participate in ongoing discussions, and contribute to the ongoing evolution of healthcare. So until next time, continue to advance your practice and stay curious. And thank you so much for joining in.